Won't be a sec. Thank you. What's going on?
Ready to go? Are we ready to go, Anna?
Yes, I'm just the record. I just need to set that up. I'm so sorry.
That's okay. Just let me know.
Yep, we're ready to go.
Okay. Well, thanks everybody for joining today. I'm Julie Vose from the University of Nebraska Medical Center, and welcome to Women in Lymphoma WiLing Wednesdays, our live webinars. And this is our series 3 on T-cell lymphoma and session 4 out of 5 today. And today we're very fortunate to have, first of all, Jasmine Zain from City of Hope is going to talk to us about newer therapies and clinical trials. And then we're going to have some case studies from Jasmine, Jia Ruan from Weill Cornell, and myself, that we're going to kind of talk about some unusual and interesting cases for different types of T-cell lymphomas. So first of all, Jasmine Zain from City of Hope, who's the Associate Clinical Professor and Director of Hematology and Hematopoietic Stem Cell Transplantation, and also specialist in T-cell lymphoma, is going to be discussing some of the newer therapies and clinical trials for T-cell lymphoma. Jasmine, thanks for joining today.
Welcome. Thank you for inviting me. And I'm going to just start. We need to share my screen. It's been disabled. Can somebody?
Yeah. Anna, I think you need to change that.
I need to, yeah.
That should be fine now.
There we go. Okay. Can everybody see my screen?
Yes.
Yes.
Yep.
Good. Thank
Great.
you.
All right, great. So good afternoon. It's afternoon in Los Angeles where I am. And I will be, I'm honored to be asked to speak about this topic of novel agents and clinical trials in T-cell lymphomas. I'm going to try to get through this. It's actually quite an extensive topic. Let me see, why is this not advancing? Oh, come on. Okay. So as you know, the prognosis for patients with relapsed refractory T-cell lymphomas remains pretty poor. We've made a lot of progress in our B-cell lymphomas, and unfortunately, overall survival for most patients with T-cell lymphoma still remains pretty bad and dismal, especially after their relapse. So we really need a lot of work to try to improve those outcomes. We do have a couple of agents, actually more than a couple, that have been approved for the treatment of relapsed refractory T-cell lymphoma, specifically for T-cell lymphoma. These are not agents that work as well in B-cell malignancies. And I have them listed here. I'm sure you're all familiar with these, starting from pralatrexate in 2009, a couple of HDAC inhibitors, romidepsin and belinostat, and then some targeted agents, brentuximab vedotin, mogamulizumab, and chidomide. But if you look at their response rates, other than brentuximab vedotin and perhaps mogamulizumab, the response rates are really in the less than 30%. There doesn't seem to be any specific histologic subtype that has a higher response rate. Perhaps the HDAC inhibitors, there's a suggestion that may have a higher response rate with it in angioimmunoblastic T-cell lymphomas. Duration of responses are again 10.1 months for pralatrexate, a little bit longer, 28 months for romidepsin, but then everything is around 13 months. Brentuximab vedotin is a special example because it has a really high response rate in ALCL, but much less in the other subtypes, even if they express CD30. And mogamulizumab is more active in CTCL and ATLL, and then chidomide is an HDAC inhibitor approved in China. So even though we have these agents, they're less than optimal, and certainly none of them is curative. So there are some other approaches used to treat relapsed refractory PTCL. We all do that. These are sort of the general approaches of treating aggressive lymphomas, things like ICE and ESHAP. There is bendamustine, which has a 50% response rate, at least in a small study of 58 patients. We use a lot of gemcitabine-based therapies. alemtuzumab, and for ALK-positive ALCL, crizotinib, which is again a very small number of patients. If they relapse with this disease, crizotinib and other ALK inhibitors are very effective. But otherwise, again, response rates may be high, but durations of responses are not great. And these are generally considered bridging therapies to subsequent stem cell transplantation. This is the NCCN guidelines for treating relapsed refractory T-cell lymphoma. Again, a lot of agents listed. They're listed in a alphabetical order, which also shows that we don't really have good ways to pick or choose these agents. We kind of decide if the patient is a transplant patient versus a non-transplant patient, and then look for regimens that are most appropriate based on side effect profile and what goals of care are. But again, at the top of each list, you can see clinical trial is preferred. So at this point, I think most academicians will agree that if you have a patient with relapsed refractory T-cell lymphoma, the best thing is to consider a clinical trial, because what we have is not that great. So I want to start this talk with talking about some general approaches to how we are looking at these different new agents in T-cell lymphomas. So epigenetic modulation seems to be very important in T-cell lymphomagenesis. We already know that 2 HDAC inhibitors, actually 3, romidepsin, belinostat, and chidamide are approved for T-cell lymphomas. They are histone deacetylase inhibitors. Vorinostat is another one which is approved only for cutaneous T-cell lymphomas. Again, I'm talking about approvals in the US. But there are several other agents or several other approaches to sort of use this for the benefit of treating T-cell lymphomas, because clearly there's epigenetic modulation that is important in these diseases. And one other approach has been to look at hypomethylating agents besides HDAC inhibitors. And I'm sorry, before I go to that, I just wanted to mention this study. This is a combination study of romidepsin with CHOP that was presented at ASH late this year, 2020. This is again a story of HDAC inhibitors sort of being advanced into the upfront setting. Unfortunately, this was a negative trial. The comparator arm was CHOP, and as you can see, I won't get into a lot of detail of this, but basically there was no difference between progression-free survival, which was the primary endpoint of this randomized phase 3 study. There was some difference in duration of response. Patients with Ro-CHOP seemed to have a longer duration of response, and that was statistically significant. But overall, when you did a subgroup analysis, there was really, very little difference between these two arms. And so this really has not been a home run. But looking at hypomethylating agents in PTCL, we start to see some activity. And this study was actually came out in 2016, or this data came out in 2016 of use of a hypomethylating agent in PTCL. Again, earlier attempts to do that in T-cell lymphomas when HDAC inhibitors were being evaluated somehow didn't pan out. But this was 5-azacitidine studied in 19 patients with PTCL, and they saw some sustained responses in patients with angioimmunoblastic T-cell lymphoma, as you can see from this swimmer's plot. Interestingly, these patients who responded seemed to have a higher response rate if they had a TET2 mutation, which makes sense because this is one of the mutations that is an epigenetic driver. So clearly, this was if you have that mutation, the response rates are higher, and this was very promising. And there has been a lot of work built up upon this initial data. So here is a study where Dr. Ruan, who's here on the panel and will be speaking to us later. This was her data presented at ASH 2020, so I hope I do justice to it. This was a combination of oral azacitidine in combination with CHOP as initial treatment for peripheral T-cell lymphoma. Again, trying to find treatments that improve that upfront response to patients and maybe even have longer durations of responses and maybe cures down the line. So again, this is a smaller study. There were patients that were untreated PTCL. There was the histologies are listed here. There were T follicular helper cell subtypes as well. And the primary response rate, the primary objective was a complete response rate. The patients received the CHOP treatment every 21 days, along with 7 days of this oral 5-azacitidine previous to it started as as an initial treatment by itself. A CHOP was added on, and then the treatment with the oral azacitidine was continued from day 8 to 21. And then here's the data to the right. You see that there were 20 patients all, and 17 of them were T follicular helper cell. Median follow-up was 15 months, and the 1-year progression-free survival was 66%, slightly higher in the T follicular helper subtype, and overall survival. And basically, this was a initial study, and the side effect profile was very reasonable, and patients tolerated the treatment well. And then she did do a mutational analysis or association with response, and found that patients with the TEP2 mutations had a more favorable response compared to some of the other mutations like DNMT3A, which is also seen in PTCL. This seemed to actually have a adverse correlation with overall survival. So again, an example of how maybe some of the newer data that is emerging in T-cell lymphoma, some of the mutations that we are starting to discover or find, how they can correlate with response, and sort of novel approaches to try to treat these diseases. Another epigenetic approach is mentioned here. This is actually combining 5-azacitidine with romidepsin, which is an HDAC inhibitor. So combining two sort of major epigenetic areas that are being investigated in cancer. And this is actually just hot off the press a few days ago. This paper came out in Blood. This is a 25-patient study, and they basically use a combination of 5-azacitidine and romidepsin. The doses are listed up there. And they actually included some patients that were previously untreated. And what they found was that the overall response rate was 61%, with a CR rate of 48%. That's pretty impressive. And it seemed to be much higher in patients with T follicular helper cell subtype, which the response rate was 80%. Hematologic toxicities were the most common ones. Here, the median follow-up was 13.5 months, with a progression-free survival of 8 months and overall survival of 20.3 months. Interestingly, responders had a higher number of genes involved in DNA methylation and histone acetylation. That's TET2 and RHO-A. Again, building on the same story that these cancers with these particular mutations probably respond well to the hypomethylating agents. So this was a nicely done study. And then EZH2 targeting. So besides just the HDAC inhibitors and hypomethylating agents, there is also the methylation of histones that is being evaluated, or another target in multiple malignancies. So EZH1 and EZH2 participate in histone methylation, and they are part of this PRC2 complex, which is a transcriptional repression complex. There is, in several lymphomas, there is a gain of function in EZH2, and in T-cell lymphomas, high expression of EZH2 as well as HDAC2 is associated with a poor survival. It's shown in the lower panel here, where the red is the low expression of EZH2 and blue is the high expression of EZH2. So high expression associated with the worst outcomes. And you can actually look at this by immunohistochemical stains. That's shown in the panel up on the upper right, where you have HDAC1, HDAC2, and EZH2 expression in various subtypes of T-cell lymphomas, including NK T-cell lymphomas. Again, this is sort of recent data. And building upon this, people have started looking at EZH1 and 2 inhibitors. These have been in trials for other lymphomas. We have tazemetostat. And for PTCL, there is a trial ongoing with velamitostat, which is an oral EZH1 and 2 inhibitor. So this is sort of, I think, one of the more promising agents that's coming down the line. It is an oral agent, and I'm just showing you data from a earlier study of 38 patients. Where an overall response rate of 80% was noted in T-cell lymphoma patients, particularly high in ATLL patients, which, as you all know, is a very aggressive HTLV1 associated T-cell lymphoma with a very poor prognosis. And this, this study has been ongoing for a while. The phase 2 is about to start in the US, and we are going to be participating in it as well. At the bottom, I'm showing you a swimmer's plot of 8 patients that were treated on the earlier phase 1 study. Again, the current dosing that has been approved for the phase 2 study is about 200 milligrams a day. And you can see some nice responses that are durable for at least 32 weeks, at least, and ongoing. So this is exciting. The phase 1 study, as I said, has just been completed. So we are awaiting the data on that and about to open the phase 2 portion of PTCL. Now moving on to some of the other targets. So another interesting story is the PI3 kinase AKT pathway. And I'm going to show you some interesting data for PI3 kinase inhibitors and T-cell lymphomas. This is sort of a diagram showing how PI3 kinase pathways are important in multiple downstream effects. And basically there is upregulation or dysregulation of PI3 kinase pathways with upregulation of activated phosphorylated AKT seen in several subtypes of T-cell lymphomas. This seems to correlate with poor prognosis in some studies. And there are now, as you all know, there's selective inhibitors of PI3 kinase that are currently in clinical development. One of them is tenalisib, which is a dual PI3 kinase gamma delta inhibitor. So this study was carried out and recently published just last year. The completed study was published. This was an oral PI3 kinase inhibitor studied in both PTCL and CTCL patients. Since it was a phase 1 dose escalation study, different dose levels were tested. And finally, an MTD of 800 milligrams was declared as a safe dose to be moved forward in further trials in the fasting state. The overall response rate in both PTCL and CTCL patients was around 45.7% with a median duration of response of 4.9 months. And the main side effects were fatigue, some liver dysfunction and diarrhea. Again, very common side effects of PI3 kinase inhibitors, as we all know. So this is an interesting agent currently being tested in other trials. I'll show you some of the combinations it's being tested in. The other big story, I think, in T-cell lymphomas is WiLing, which is another oral PI3 kinase inhibitor. A lot of us have participated in this study. And this was initially, it came out of Dana-Farber on a, the initial work was done on patient-derived xenograft models. And it was shown to be an active agent. And the initial trial was a dose-finding trial of 2 different dose levels, 25 milligrams BID and 75 milligrams BID. The response rates on the 75 milligram BID cohort were much higher. They were about 62% versus 40% in the 25 milligram BID cohort. But the side effect profile was also much different, and the agent was a lot more toxic with more liver toxicity and GI issues on the higher dose. So as a result, the trial has now been, it was then changed to a schedule where the patients received 75 milligrams BID for the first 2 cycles and then 25 milligrams BID going forward. And this trial has just recently been completed. This has been the dose expansion study. And we're waiting the results, but it's expected that the response rates will be upwards of around 50% at least. The initial studies were about 52%, so it should be around there. And the side effect profile, again, liver dysfunction, rashes, some GI issues have been noted, but with this new sort of dosing schedule, the side effects are more manageable in patients. So this is going to probably go to registration and possible approval. But of course, we think about combinations. As I showed you data with tenalisib single agent, it is now being studied in combination with romidepsin. Again, there is preclinical work to support a combination of an HDAC inhibitor with PI3 kinase inhibitors. And this is ongoing. No major side effects seem to have been noted so far. Duvelisib is being studied with romidepsin as well. Overall response rate of 55%. Again, the study is ongoing. It has been studied with bortezomib as well. Serdalutinib is a dual SYK and JAK inhibitor. And this was presented at ASH 2019, the Celtic study. I believe it's still ongoing. I didn't participate in this. In this interim analysis, there are 60 patients treated with an overall response rate of 35%. The PI3 kinase inhibitors are also being looked into to see if we can move them into the upfront therapy. So combinations of CHOP and CHOEP are being proposed. I believe this will be studied in alliance with a couple of other upfront combinations. There is talk to consider this in combination with BCL2 inhibitors and possibly with other HDAC inhibitors. Just moving on to some of the other pathways, the JAK-STAT pathway is also dysregulated in multiple T-cell lymphomas. And so there has been a study of the JAK inhibitor ruxolitinib in patients with relapsed PTCL or CTCL. This is an interesting study, and I think Dr. Ruan has been part of this as well, where patients were put into cohort, relapsed refractory patients with PTCL or CTCL were divided into cohorts based on NGS analysis of tumor biopsies to see if they had upregulation of phosphorylated STAT3 or if they had the JAK1 or JAK2 mutations. The patients got 20 milligrams of ruxolitinib twice a day till progression, and 53 patients have completed therapy with an overall response rate of 23%. There was some clinical benefit, and it didn't seem like several, the different cohorts seem to have very similar response rates. And so this is another potential agent that could perhaps be studied in combination with other agents. CD38 directed therapies, another interesting target. It was noted that CD38 expression is seen in several, particularly NK T-cell lymphomas, and may have prognostic significance. And we have an interesting agent, daratumumab, that targets CD38 and induces antibody-dependent cellular toxicity. So this agent was studied in 32 patients with NK T-cell lymphoma. Again, this was presented at the recent ASH meetings. The median follow-up was, presented in 2019, and the publication came out in 2020. The median follow-up of these patients was 16.7 months with an overall response rate of about 25%. Interestingly, they did not see any response association with the degree of CD38 expression, but they did see that there was a decrease in EBV DNA reduction more commonly seen in responders, which makes a lot of sense because NK T-cell lymphomas are associated with EBV activation. So here are some of the combination therapies that are being looked at in the upfront setting. Some of these studies have been completed. The lenalidomide has been studied with CHOEP because as an immune modifier, 39 patients were studied. There are a lot of hematologic toxicity. Lenalidomide has been evaluated with CHOP in the T-cell consortium on 37 patients with an overall response rate of 54%. You have pralatrexate plus CHOP or full CHOP. 12 patients, response rates 89%. Again, trying to build up on the CHOP responses and maybe having a longer duration of response. Really, the only success story so far has been the combination of CHOP with brentuximab, and we are all aware of that data in Echelon 2. Here are some of the doublets and triplets of the targeted agents. And again, I won't go into details of that. They're present on your list because I do want to talk about some of the other interesting approaches to treat T-cell lymphomas. And that is immunotherapies. As you know, immunotherapies are the hot topic of oncology right now. There's multiple approaches, not just direct antibodies, but also bispecific antibodies, checkpoint inhibitors, and engineered T-cells. Regarding checkpoint inhibitors, they have really not been that successful in the treatment of T-cell lymphomas, but appear to be active in NK T-cell lymphomas. These initial reports from 2017 from Hong Kong showed very impressive responses of pembrolizumab and also then nivolumab in patients who had relapsed relapsed NK T-cell lymphoma, even after an allogeneic transplant. So that was a very promising signal. And based upon that, there have been further work done. There's several checkpoint inhibitors currently in trials for NK T-cell lymphomas. And this was an interesting study that was presented at ASH, which is an upfront study of sintilimab, which is a PD-1 inhibitor with GemOx and pegasparaginase as first-line therapy for advanced NK T-cell lymphomas. So this was after the first 6 cycles of chemotherapy, the patient had maintenance sintilimab for every 3 weeks for 2 years. And the overall response rate, even though only 6 patients were presented, was about 100% with a CR rate of 33% and acceptable toxicity. So again, an interesting approach, again, moving some of these novel agents into upfront therapies, hopefully with the hope of improving to overall outcomes of these patients. So then these checkpoint inhibitors are also being evaluated in combination with other agents for T-cell lymphomas and not just NK T-cell lymphomas, with the idea that perhaps adding another agent or cytotoxic chemotherapy may prevent some of the hyperprogression that is associated with with checkpoint inhibitors seen in T-cell lymphomas specifically, but may also enhance some of the responses that are seen with cytotoxic chemotherapy. So we completed a trial of nivolumab with EPOC as an upfront therapy for T-cell lymphomas. This trial is completed. Some of the biomarker analysis is pending. Pembrolizumab is being considered, is being evaluated in combination with a PI3 kinase inhibitor. City of Hope has a trial of pembrolizumab with pralatrexate in relapsed refractory PTCL. So again, these combinations are being evaluated, results are awaited. And then in terms of some of the other interesting agents, this is the CD47 blockage. It is enrolling the macrophages as an anti-tumor agent by binding to CD47 and blocking the SERP alpha pathway. This approach has been successful in the treatment of B-cell lymphomas, and it made it to New England Journal of Medicine in combination with rituximab. For T-cell lymphomas, there is some data to support that CD47 inhibition is active. We did a study at City of Hope of intratumoral injections of a CD47 blocking agent from Trillium, and we saw some interesting responses both in the injected tumors and in the non-injected tumors. So this is possibly an approach that can be looked at in combination with other agents, and trials are ongoing. I do want to talk a little bit about bispecific engagers in T-cell lymphomas, and I think one promising one is the CD30 and NK cell bispecific engager, taking CD30 in combination with the CD16 that engages an NK cell. The agent is called AFM13. It has been in clinical trials. Phase 2 is ongoing right now for registration purposes. In clinical development, the preliminary data was promising in several subtypes of T-cell lymphomas. Again, these patients had failed brentuximab vedotin, and tumor shrinkage was seen in about 62% of patients with a favorable safety profile. One combination of this agent, it's also being studied in Hodgkin's lymphoma, is with a checkpoint inhibitor, but currently the trials for T-cell lymphomas are just as a single agent. One other bispecific antibody is the CD25 antibody conjugate with PPD. This is the camidanlutamab tesirin agent. Again, studied more heavily in Hodgkin's disease, but the initial phase 1 study actually included some T-cell lymphoma patients as well. And the responses were seen at doses more than 60 micrograms per kilogram. At the moment, they're focusing on Hodgkin's lymphoma, but certainly an agent to keep in mind for further development down the line. And I wanted to mention a little bit the CCR4 antibody agent mogamulizumab, which was approved for cutaneous T-cell lymphomas and Sézary syndrome, but it certainly is a target that is expressed in T-cell lymphomas as well, particularly ATLL, and has been combined with chemotherapy to try to improve, outcomes of chemotherapy. So this is a study that was published in 2015, combination chemotherapy with mogamulizumab in patients with ATL. And as you can see, that the combination was at least tolerated well, even though the results were not very impressive when compared to chemotherapy alone. But it is being evaluated both in combination with pembrolizumab as well as other agents for T-cell lymphoma. It has been combined with EPOC, and that seemed to improve outcomes, both overall survival and progression-free survival, at least in one study. CAR T-cell therapies have arrived for T-cell lymphomas this year. So I just use this slide to show that, things have happened in 2021, which is, and one of them is CAR T-cell therapies. We opened our first CAR T-cell trial at City of Hope. Problems with CAR T-cells for T-cell lymphoma have been challenging. Some of the challenges have been fratricide. Finding the right target has been challenging because you want to also not result in T-cell aplasia. You don't want to immunosuppress patients and get rid of their T-cells completely. There's also the issue of product contamination of getting T-cells from when you do the leukapheresis for production of CAR T-cells, you could have a tumor contamination, and you may end up introducing the CAR into the tumor cell. So a lot of approaches have been, people have had to use newer approaches to overcome some of these challenges for creating a CAR T cell for T cell lymphomas. It has included looking for novel targets, or also using splicing to get rid of some of the markers of T cell like CD5 or some of the MHC and HLA markers on T cells to to overcome issues of fratricide, or use non-T cell CARs. So the first trial that we opened at City of Hope was the CD70 CAR. It's an allogenic product, so you don't have the issue of contaminating the product with tumor cells. And it targets CD70, which has been shown to be active on lymphocytes and upregulated in some T cell lymphomas and other malignancies. So this is a novel CAR T cell where they have actually used the CRISPR technology to knock out the TCR expression. They also knock out the MHC1 expression and thus get rid of any concerns for GVHD. And then the CAR is introduced, and then the cells are used after the usual lymphodepleting therapy. They're injected into the patient. It's a phase 1 dose escalation study, so we're just currently on dose level 2. I just wanted to show you an example of a patient with advanced cutaneous lymphoma who received this therapy with some very impressive responses by day 16. Some of the other CAR targets, obviously CD30, which is an obvious target for CAR T generation. This is an ongoing study, and it's again being studied in Hodgkin's lymphoma, but a CD30 CAR autologous product is also being studied in T cell lymphomas. So that's ongoing, and we'll have some results hopefully by the end of this year. Other CARs, there's several out there right now. There's a CD4 CAR, there's a CD5 CAR, and there's a whole list of clinical trials that are ongoing using CAR T cells for T cell lymphomas, and we are eagerly awaiting those results. And with this, I want to thank you and leave some time for the case discussion. This is our Japanese garden at City of Hope in Springs. So thank you very much for giving me the opportunity to speak about this. Thank you. Any questions?
Thanks, Jasmine. I think we'll go ahead and go to the case discussions and then maybe take all the questions at the end in case somebody thinks of some other ones, if that's okay.
Sure.
So we're going to move next to the case discussions. So in addition to Jasmine, we have Jia Ruan here from Weill Cornell. So she's an associate professor there and associate attending professor at New York Presbyterian and director of the T cell program. And then I have a case I'm going to present too. So I'm going to try to share my screen here so we can get the slides up. Okay, can you see my slides okay?
Yes, yep.
Okay, great. So the first case I'm going to present is a really interesting one, and something just happened this week to make this even more interesting. So this patient is a 25-year-old African-American male who presented with about a month's history of abdominal fullness, drenching night sweats, thrombocytopenia, weight loss. He really had no significant health issues before that. He was healthy, had gone to college, was a basketball player. His labs, he actually came in because of that and also because he said he had a rash on his skin. Oops. Sorry, let's go back up here. So his lab showed a white count of 9.1, hemoglobin 11.6, platelets 52,000. You can see his liver functions were slightly up, Billy was up, albumin slightly low, and his LDH was 1230, so very elevated. And he had a very large spleen on exam, as well as a hepatomegaly. So this was his initial scan, just showing the extensive hepatomegaly there, and splenomegaly. Because of the cytopenias, we did a bone marrow biopsy. We thought was the easiest way to get a diagnosis. So this is just the low power view of the bone marrow, just packed, very, very involved. And I'll go over kind of the stains in a minute, but he had a kind of a sinusoidal distribution in the bone marrow upon staining. And the diagnosis then was showed the, of course, the normocytic anemia with thrombocytopenia, and bone marrow was about 95% cellular, with involvement of a T-cell lymphoproliferative disorder, most consistent with hepatosplenic gamma delta T-cell lymphoma in about 30% of the marrow space. And down below, it shows the staining. So it was positive for CD3, CD2, CD7, CD16, 43, 56, and gamma delta, and double negative for CD4, CD8, and CD5. So most consistent with hepatosplenic. And they also, of course, did T-cell gene rearrangements and TIA1. So the patient didn't like what I told him I was going to do for a treatment. Sounded kind of aggressive for him. So he decided to go to Mexico for a holistic treatment. And he just showed up on Monday of this week back with severe abdominal pain, not too much of a surprise. And his white count now was 55,000. Lots of circulating cells. Hemoglobin was down to 7.5. Platelets, surprisingly, were 79. LDH, very elevated. Liver function test. And a CT was done, which showed his spleen was even bigger now, and also had a lot of infarcts in it. Not surprising that he had so much abdominal pain. So for induction therapies, there's small studies for this because it's pretty rare. There's not any, huge studies, but a lot of different things have been used. I chose to treat him with IVAC. I've had the kind of best luck with the ifosfamide containing regimen, but there's certainly literature for using many of these other regimens as well. And also, we're hoping to do an allogeneic transplant in first remission. I usually try to do 4 cycles of IVAC and see if I can get them into a good remission and then proceed with allogeneic transplant. So that's the plan in this gentleman, but I'm anxious to hear what Jasmine and Jia would say as far as the regimen you'd like to use, and do you agree with the transplant in first remission?
So I can answer that. I agree with the second part of your the allogeneic transplant in first remission for sure. I mean, I always try to do that. In terms of induction regimen, again, as you mentioned, there's no real consensus on what to use. CHOEP, I use a lot of CHOEP. IVAC is certainly a great idea as well. A lot of time I find it's very hard to get these people into remission, which is really the biggest challenge. We've had some luck with CAMPATH once or twice, I must say. So
yes, there is some literature with that. Yeah.
Yeah. But otherwise, I think the goal is really to get them into transplant as quickly as possible. And I know a lot of them don't like hearing that. It's really hard to convince patients to sort of try to understand how aggressive this is.
Right.
And no prior history of any use of one of those TNF agents or anything.
No TNF agents, no prior medical history, no nothing. So a little bit unusual in that respect.
Yeah. It's unfortunate. The
Yeah.
The other question I had, sometimes we've had to do, I mean, sometimes it's happened because of the need for diagnosis. There's been a splenectomy done, either to get a diagnosis. And I actually have one patient, again, the numbers are very small, who's actually done very well after a splenectomy, I must say. That she's like 4 years out. I can't find a donor for her. She's one of those rare people, but she just keeps going. Disease comes back, we treat her on a little bit, but it's really her bulk of her disease was in the spleen and was taken out.
Yeah.
So there is some role of that as well, I think, in some patients.
Yeah, I did actually have the surgeons kind of look at him just because I wasn't sure if we're going to be able to, get him into remission or what was going to happen with his infarcted spleen. And his spleen is like hard as concrete, basically. And they kind of looked at me like, "Are you kidding me?" But sometimes you got to do it, right?
Yeah, because the counts become an issue, right? It's sometimes if the spleen is that big, you just can't get the treatment in. And
right.
So
well. And Jia, what do you think?
Yeah. Hi, Julie. So I would be completely in agreement with your approach and what Jasmine was discussing, and I think we try to approach that very aggressively, if that's relatively young patients with good performance status, and type them, HLA type them right away, with the goal of going to consolidative allogeneic transplant. But first, try to get them into CR. So, we actually use a lot of IVAC type of regimen, the cytarabine, and it's sort of like addressing the bone marrow, like, all this hematopoietic tissue fairly effectively. So I would be in agreement. We have tried like CHOP or CHOEP type of regimen in somebody who's coming with really diminished, performance status or kind of borderline age group per se. And then, the difficulty with, they may not be able to get into a very good quality response. And that then, you go through, I guess, salvage treatment and cycling through different agents. They are usually not very effective, I would have to say.
Yeah. I think kind of the first time is the best time, and we need
Correct.
to
Correct.
keep in remission.
Yeah. We've seen really good response, especially younger patient group, and having great match for allogeneic donor, and like, uneventful transplant course. And we've got long-term survivors doing extremely well. And then we also have others who may not have a very well-matched donor, or we've had haplotransplant, and the outcome can be variable.
Yeah, so he has one sibling and a bunch of half siblings, and so we'll proceed with typing as possible. Of course, he's African American, so an unrelated donor is going to be a little bit more difficult to find as well. But I'm happy to say after 2 days of chemo, his spleen has shrunk considerably, actually.
Oh, wow.
So hopefully you'll have a good response to that.
Yeah.
So you can go to the second case, which I think is Gia's case. So just let me know when you want to change the slide here.
Okay, we can advance next. Thank you so much, Julie, for inviting me to this. And this is really exciting. And Jasmine, I really enjoyed your talk, which is excellent. So I want to share this case, actually a couple of cases, and it's actually under the same umbrella diagnosis. And just to illustrate that there's certainly heterogeneity in terms of clinical presentations, biomarkers, and so therefore attention to details is really helpful. And many of those clues can help to guide treatment selections or discussion about prognosis and et cetera. So I'll start with case 1 and then go on to case 2 and then provide a very brief background discussion. The first case is a 65-year-old woman, previously healthy, but has a bunch of comorbidity, well managed, came into our clinic after a very brief vacation in Florida with profound fatigue, just generalized swelling, and a new lymphadenopathy. On exam, there were lymph nodes palpable pretty much everywhere. And her labs essentially showed anemia and, quite low albumin, elevated LDH. And because of the stress, her glucose was elevated as well. And interestingly, she has a EBV viremia on our laboratory testing. She underwent a PET CT, basically showed quite extensive hypermetabolic lymphadenopathy above and beyond, below the diaphragm. There were one very obvious lymph nodes to be probed for biopsy, and SUV was quite high to 11. And she also has moderate splenomegaly. And so next, we aimed for that axillary lymph nodes for excisional lymph node biopsy. Basically, it came back, was consistent with angioimmunoblastic T-cell lymphoma. As you can see here, because of the space limitation, I only included just a few slides. At this particular magnification, it's hard to appreciate the arborizing, high endothelial venue, but it really just kind of highlights its heterogeneous inflammatory infiltrations, and it's intermixed with atypical large cells, but lots of other sort of immune cells. And the IHC basically showed they were T cells, CD3 positive, CD5, and loss of CD7. There's variable CD4 and 8. It's very distinct PD1 ICOS, positive expression, but other markers like CD10, BCL6, those were negative. Ki67 was quite high, which probably explained, her SUV and also clinical presentation features. She had CD30 negative. In our institution, it's like less than 5%, or, I usually double check with our pathologist just to be sure which one they were highlighting for the CD30. Bone marrow biopsy was also down, which showed hypercellular marrow with a kind of small infiltration of atypical lymphoid cells, and the IHC basically confirmed those were T cells. And we did molecular on both the lymph nodes and marrow. Basically, it shows monoclonal. I do believe it's actually biclonal rearrangement, but it's identical in those tissues. And we did B cell molecular study as well. Those were polyclonal. So, the infiltrations were polyclonal B cells. So the diagnosis was quite clear, angioimmunoblastic T cell lymphoma. The second case was, it's actually an earlier case, and a patient referred from Ithaca Upstate, and we do a lot of collaboration with physicians there. Kind of, it's part of the Cornell system. And so she was seen by a local physician because she has very asymptomatic leg skin nodules. And at that point, she, had presented with also fatigue, B symptoms like night sweats, lymphadenopathy, and she has nodes, and she also has nodular skin rash, which looks like a sort of erythema nodosum type of picture. They were thinking that she might have rheumatological presentations. Her labs basically showed pancytopenia with low white cells, anemia, and again, she has elevated LDH. They looked for EBV, but they couldn't find in this particular case. The PET CT basically showed hypermetabolic lymph nodes. Again, she also has moderate splenomegaly. And so they did a lymph node biopsy, which is shown next. This time it came back, it looks like a PTCL. Initially it was read at Ithaca Hospital as PTCL NOS. So our pathologist took a more detailed look at it, and morphologically, certainly it was kind of indistinct, but it looks like a garden variety PTCL NOS. And when they requested more cell blocks and doing more markers, it came back, it was CD10, BCL6 positive. And this case actually has quite significant CD30 expression, and it appears to be highlighting those atypical T cells. And I included those BCL6 and CD10 markers here. Bone marrow biopsy was done, and essentially they did not find any evidence of lymphoma. Interestingly, they also did a skin biopsy, which only showed infiltration of a benign looking inflammatory cell. So they thought it was like a neoplastic presentation of reflecting her underlying malignancy. Molecular study was done on her lymph nodes, and again, it was monoclonal and goes along to support T cell lymphoma. So our revised diagnosis was PTCL with T follicular helper phenotype, and which kind of goes into this umbrella new provisional WHO 2016 classifications for T cell lymphoma. So now we have actually within one entity, we have sort of different subgroups, and they are threaded together by a common molecular signature that reflects cell of origin of this T follicular helper cell. And that certainly includes the angioimmunoblastic T cell lymphoma. I would say, maybe less than 30% previously, but if you added those T follicular helper PTCL, which is about a portion of the PTCL NOS, then that particular provisional group sort of grew a little bit, maybe a third, maybe up to 40%. I mean, it's interesting just because now we know that there is rationale behind it, because it help us to understand or study the biology, but also sort of provides some roadmaps in terms of what potential pathways that can be targets for therapies. And also, I think now that we're on fairly high vigilance and alert in terms of requesting antigen staining, for PTCL, just to make sure that we don't miss any easily obtainable TFH markers, which is listed here, the PD-1, CD10, BCL6, etc. 2 out of 3, those are required. And like I said, the molecular genetic mutations of TET2, DNMT3A, and IDH2-RhoA. So next, in the next slides.
There we go.
Okay, thank you. So I want to say that in the first case, we actually sequenced whole genome that patient actually had TET2 and IDH2. So clinically, it tend to be it's quite common in Western countries, and as we learned that they can be kind of explosive, but we have seen more indolent variety on the minority side, and we see some immunological manifestation, polyclonal or monoclonal gammopathy, skin rash could be present, EBV association in the B cells per se, and variable CD30, I want to guess like maybe 30–40%. We always looking for TCR gene arrangement. It's part of our diagnostic kind of focus, but we won't be deterred if they come back sometimes with B cell rearrangements, because it's possible it's polyclonal or monoclonal. Sometimes we see a concurrent DLBCL or develop into DLBCL, but we just kind of treat as needed. Next. So just, like in terms of treatment, part of the reason that we wanting to know everything about diagnosis and biomarker is because we want to incorporate what's available out there and what potentially can be beneficial. So for example, now that we want to know CD30 status, because of echelon-2 data, that even though it's not part of the powered objective to see if it's actually benefiting angioimmunoblast T-cell lymphoma, nonetheless, we're hoping that it adds some firepower. And as Jasmine discussed earlier, that RoChop was, that is a combination, but at this point, we probably won't use that off-label or off-study. And there were a couple of studies, perhaps more than a couple, but 2 that was reported with LAM plus CHOP, CHOEP. In anybody who's over 60, we're probably just going to use CHOP backbone. And they were sort of not terribly impressive. I think part of that was masked by toxicity. So, and then we had a very preliminary exploratory small study, but that we hope to expand into larger studies and with other comparator arms. So it's kind of interesting. We want to think about biomarkers, and we want to select if it's chemotherapy-based treatment or not. There's also chemo-free combinations, but that's beyond the discussion for today. Next. So in those 2 cases, one of the patients with CD30 positive PTCL, they were treated with BV-CHP, and we aggressively pushing anybody who can get transplant onto transplant. So even they were 75, a great 75 that went on successfully with transplant consolidation. And subsequently, she required some BV about 3–4 years, 2–3 years later, but still doing great. And then this first case on the study, we did transplant as well. And then we have, some backup thoughts and, as needed. So I'll stop here. And I'm so sorry, I took a lot of time.
That's great.
Great case, great cases.
Yeah.
Great discussion.
Yeah, this type of patient's always tough. I wish we had more data on using the directed therapy with the molecular techniques, and hopefully we'll get there soon through some of these trials that are going on. But certainly, if the patient is CD30 positive, to add BV would be the thing to do for sure.
Sure.
So. Jasmine, any thoughts from you?
No, I mean, I think this is exactly what we do. Clinical trial, if we have one BV-based therapy, I still go with that if there's CD30 expression, even though I know there's a lot of concern about the data in echelon-2, and then transplant.
Right.
Again, we go as high as we can, 75 and above, depending on their age and so on. I don't think I would go beyond 80, though. It gets to be tough then. And then second line therapies. again. I mean, some of these patients have an indolent course, I must say. Even with aggressive presentation, I've found that initially, once you get them through, they tend to get sometimes, not always. And I wish we knew which ones are going to do that way, which ones are going to have the less aggressive course. And the interesting thing is they don't have a lot of bulky disease, right? So there's something about angioimmunoblastic, the lymphoma, at least especially in advanced stages or relapse disease. The disease is not bulky, but the patient's pretty sick. So I think there's a lot of cytokine stuff going on that we could probably work with.
Yeah.
This is a very interesting histology, I must say. This whole group of, the T follicular helper cell.
Yeah, it can be deceptive, I think. Yeah.
There's a lot of different types of lymphomas within that one type. So
Correct.
Someday we'll figure that out.
Yes.
All right. So this is the last case from Jasmine.
I mean, how much time do we have? Because I could do it faster.
Well, not too much. Just
okay. If you want to, I can take over and then I can go to the important slide.
Yeah, sure.
Okay, let me do that. Request. Okay. So where is the share screen? Okay. So then I don't have to.
Sure.
Okay. Can you see my case?
Yes.
Yes.
So, oh God, get stuck. Okay, so this is a 57-year-old patient presented with acute abdominal pain. Prior history was, typical diabetes, hyperlipidemia. No real previous medical history, particularly that of celiac disease or GI issues. And somehow my scan's not showing through. Okay, here we go. The patient presented, had a CT scan, and she had pneumoperitoneum with a perforated viscus and was taken to an emergency laparotomy. And then they resected out part of her jejunum and part of her ileum. And as you can see, this is a very cellular infiltrate. This was under the microscope. And I'm not going to go into all the details of the different, but the final diagnosis was METL, monomorphic epitheliotropic intestinal T-cell lymphoma. No prior history of gluten sensitivity. And basically, this was her PET scan after surgery. Obviously, they couldn't do it at the time of surgery. So really no significant disease at this point. She had an additional, I didn't put that up on the slide, when they took out the appendix, it had a mucinous adenocarcinoma there, which again, was very localized and there's no further treatment for that at the moment. Okay, so this is again a rare form of T-cell lymphoma. There are two major types of intestinal T-cell lymphoma. One is ETL, which is associated with celiac disease, and then this or celiac sprue. So that's called entropathy associated T-cell lymphoma. And then this other form, which is not associated with celiac disease, is METL. The median age is very variable between 23 to 89. And most of the time it presents in the small bowel, could be the large bowel as well. And that it creates an interesting problem of how do you follow this disease, which is why I'm presenting this case. There can be bone marrow involvement. Obviously there's GI symptoms. There's not a lot of nodal disease, but you can have abdominal masses as a single lesion or even multiple tumors and ulcerations, nodules, and you can have obviously perforation. One other interesting thing that I have always been found challenging with these cases is how to follow them. If there's a tumor mass or lymphadenopathy, you can follow it with scans or even a PET scan, but PET scan is not great for intestinal disease. So MR angiography is a form that has been recently evaluated for treatment of, for diagnosis and follow-up of small intestinal lesions, particularly lymphomas. So this is something that we have started using in these patients to try to follow, the effects of treatment. Obviously you get a baseline and then follow along, because otherwise you need to do, if it's a large intestinal involvement, you'll have to do colonoscopies, and small bowel is always very difficult to evaluate endoscopically. In this case, the molecular findings for both ETL and METL are similar. They can have chromosomal alterations. Most common mutation is the SETD2 and STAT5B mutation, but you can also have the JAK-STAT or RAS mutations. There tend to be EBV negative, and of course the usual features of TCR gene rearrangements are seen. So here's a differential diagnosis. You can have other types of T-cell lymphomas or other lymphomas present in the intestine as well. There's also the subtype of this indolent T-cell lymphoproliferative disorder of the GI tract, which I call the MF of the intestinal tract. It's CD4 positive, very, very chemo resistant, but kind of indolent. Patients present with abdominal pain, diarrhea, almost like an inflammatory bowel disease. And I found that very challenging to treat. They do have to have an indolent course though, but they're very miserable. And then, of course, you have to differentiate it from some of the other autoimmune and inflammatory diseases. The treatment, again, like other T-cell lymphomas, is not standard. There is the Newcastle regimen, which where they use, it's basically a regimen which starts with CHOP. It has methotrexate in it as well. It's a combination chemotherapy. It's followed by autologous stem cell transplant. In this case, they found a 60% overall survival at 5 years and a good progression-free survival. Most patients should be taken to an autologous transplant. That was part of the EBMT report. And also in the Nordic lymphoma study, there were a few cases of intestinal lymphoma that underwent an autologous transplant after initial therapy to try to get a longer remission. Then there's a couple of other studies in Korea that have looked at different ways of evaluating these patients after autologous transplant. But really, though, there is no standardized treatment as expected, like some of the other subtypes we talked about, other than transplant. But there is some role of surgery because these patients usually present with an acute abdomen, so they end up having to undergo surgery. Some of them have surgery to confirm diagnosis, but it's not in the treatment algorithm. But I think that in this particular patient, she's had surgery and she actually has no disease right now. So I'm actually planning to give her 4 cycles of CHOEP chemotherapy and take her to an autologous transplant. And that's kind of what I've decided to do. And I'm happy to, if anybody has any other suggestions, I'm happy to entertain that. So I want to end here because I know we're running out of time.
Yeah, I find these cases really difficult for the reasons you said. They're hard to follow the patients, and they don't really have disease that you can see very much on scans, and just really difficult to tell if it's active disease or toxicity or infection or what. But I have used the Newcastle regimen with some success in transplant.
Okay, all right. Jia, what do you think? What's your experience?
Not too much. but I want to say that just today I saw somebody that was referred to us, but had an ETO that was watched and waited for like 10 years. Now it seems to be exploding, with lots of lymph nodes and stuff. So we're going to rebiopsy just to see if there's any other markers and if it's kind of developing to something that's I'm sure more complex and proliferating state.
Okay. All right, great.
All right. Well, before I forget, because I always forget this part, I'm supposed to thank our sponsors, MSD and Roche, and we're going to open it up for questions now. There was one question earlier that was about, I think, my presentation. Do you need to try multiple 4 rounds of IVAC before proceeding to transplant, or can you proceed in PR or primary refractory? I would say that your best chances are if you can get the patient in a CR from that type of lymphoma. You don't want to go too far though, then put it off and have them relapse. So there's kind of a fine balance there to take them at the right time to transplant, I would say, in that first case I presented. Any other questions anyone has that we can talk about? I don't see any other in the chat box here. Or any other cases anybody wants to talk about? Okay, well, I guess we were very clear in that case. So again, I want to thank Jasmine and Jia for presentations and cases today, and hopefully everyone will find this educational, and we'll hopefully see you next week for our last of this series in the T-cell lymphomas, and we're going to do some kind of professional development and interview some sort of mid-career senior people and junior people and kind of talk about how they got to where they are today.
Great.
So,
Thank
all
you.
right. Thank you so much.
Thank
Thanks,
you.
everybody.
Good cases. Thank you very much.
Thank you.
Bye.